Good morning, student. Today's your humerus shaft fracture patient management. The humerus shaft fracture represents a significant portion of all fractures impacting upper limb function. This presentation outlines the effective patient management strategy. Anatomy and fracture classification. The humerus shaft extends from the surgical neck to the supracondylar ridge. A crucial anatomical consideration is the radial nerve, which passes through the spiral groove, and it's a susceptible injury during fracture. Then fractures are commonly classified by the pattern, including the spiral, oblique, transverse, comminuted, and segmental fractures. Then according to the AO and OTA classification system is widely used for detailed surgical planning, providing the standardized approaches to describe the fracture characteristics. Mainly the diagrammatic approximation. First, we'll see about the edge of the regular line is the spiral nerve. That is the end of the spiral attached to the spiral goal. Then feeder cap. Then diagnosis and assessment. The clinical examination. Pain, swelling, deformity, and inability to move the arm or indicators to assess the any open wound. The neurovascular assessment, that is crucial to check the radial nerve function, that is the wrist drop and thumb extension or sensation in the hand. Then comprehensive imaging, anteroposterior and lateral radiograph from shoulder to elbow or sternum. CT scan may be needed for complex cases for surgical plan. There is a intra-articular fracture or any disruption of the head. Then non-operative management. Approximately 80 to 90% of the closed humerus shaft fractures are successfully managed non-operatively. The goal is to achieve the acceptable alignment for healing. That initial mobilization, that is, utilize cooperation is a sprint or use slab to stabilize the fracture early on. Then functional bracing. The Samito brace is a highly effective method, achieving the 90 to 97% of the union rates. Then early mobilization begins gentle shoulder and elbow range of motion exercises as pain allows to prevent stiffness. Then operative management. Surgical intervention is indicated for specific situation, offering the distinct advantages depending on the fracture type. Techniques. Open reduction internal fixation, plates and screw. That is mainly for preferred for comminuted fractures providing high intensity. Provide for comminuted fracture providing high stability and risk of iatrogenic radial nerve injury for 3 to 5%. Then intramedullary nailing, that procedures for less soft tissue disruption. Ideal for simple fracture pattern. Then external fixation, used for severe open fractures or as a temporary stabilization method for fractures fixation. Then potential complications. While most humerus shaft fractures heal successfully, it is essential to aware of potential complications. That is radial nerve palsy. The most common complications are the 10 to 18% of the primary incidence, with approximately 90% of the resolving spontaneously within 3 to 6 months. Then non-union occurs in the 5 to 10% of the cases, defined as no healing by 6 months, often requiring for further intervention. Then malunion, the functional deformity resulting from the fracture healing, is an unacceptable alignment. Then infection or stiffness. The infection is rare for close to fracture, 1 to 5%. Open stiffness can adjust the joint and other shoulder and injuries. Then rehabilitation and recovery. A structured rehabilitation program is crucial for restoring the full upper limb function. The immobilization phase, that is for 0 to 6 weeks, with a focus on the protecting the fracture site and a gentle range of motion for adjacent joint to prevent stiffness. Then early mobilization, 6 to 12 weeks, will go for progress to active assisted and active range of motion with introduction to light rest strengthening exercise. Then strengthening exercise for functional recovery, the 12 weeks plus, is a progressive resistance exercise focusing on the regaining the strength and endurance for daily activities and return for sports. Then full fracture union typically occurs within the 8 to 12 weeks, then with functional recovery extending into 4 to 6 months or monthly for physiotherapy is essential for throughout the process. Then conclusion and key principles. The most humerus shaft fracture respond well to non-operative treatment, achieving high union rates. Then surgical intervention is targeted approaches for specific complex indication. Then through assessment of the radial nerve is a paramount of the fracture evaluation. Then a comprehensive rehabilitation program is crucial for achieving optimal and long-lasting functional outcome. Patient education and adherence to treatment plan is critical for successful recovery.